get started. 7:32. So I'd like to welcome everyone to this week's Grand Rounds. Continuing the cornea theme, we have Dr. Clara Chan, who's an assistant professor of ophthalmology in our department and a specialist in cornea, cataract, and refractive surgery, and one of the fellowship preceptors for our cornea fellowship. Dr. Chan is quite the dynamo and quite accomplished. She's the president of the Canadian Cornea and External Diseases Society and has already received the AAO Achievement Award in 2015 and has been on the Cornea Clinical Committee at the ASCRS. As well, she was on the 2021 Ophthalmology Power List. So quite an extensive resume for someone so early in their career. So I'm sure everybody knows Dr. Clara Chan, but I want to formally introduce her. Clara, the floor is yours.
Thank you for the nice introduction and the opportunity to lead today's Grand Round cases. We're going to have 3 cases being presented by 2 of our residents. We'll just get right to it so that we can get through everything in the time that we have. So Sheikha will start.
Okay. Hello, my name is Sheikha Mohammed. I'm one of the PGY3 residents at the University of Toronto. I'd first like to thank Dr. Shai Gedler and Dr. Clara Chan for helping me prepare this presentation today. We're here to discuss a 28-year-old female who was referred for a keratoconus consult and cross-linking. She was complaining of blurry vision over the past few months. She has no medical history, but did undergo ptosis correction surgery at the age of 6 years old and was diagnosed with keratoconus in Korea. She's currently on cyclosporin drops using 2 times daily. On exam, her best corrected visual acuity was 20/30 on the right and 20/30 plus on the left. Her pressures were normal and she refracted to -8.5 with a 3.7 plus SIL on the right, axis 116, and -7.25 with a plus 275, axis 75 SIL on the left. So let's start with the corneal topography.
Okay, I can't, the residents on the Zoom screen are really tiny little dots. So can I ask one of the PGY3s to describe what they see on the topography, please? Otherwise, can you see who's there? And we're going to call on someone.
Okay, hi, Dr. Chan.
Hi.
Hi, I think I'm from PGY3 here. Okay, so I see photos of topography, the right eye on top and the left eye on the bottom. I think what we're looking at here is there's some inferior steepening to point out. And
can you comment on the quality of the scan?
I think the scan is of reasonable quality, although I guess the pupil isn't completely dilated.
Yeah, dilation doesn't really matter so much with topography. We're looking at the cornea surface. And so what's your differential at this time with just this image that we have?
So I guess the top of my differential here, especially with this case, is keratoconus, but also just inferior steepening that does not qualify to be keratoconus yet, and other like Terrian marginal degeneration.
Any others? You can ask a friend for help.
Any friends can help me now.
Just shout out what you're thinking.
Lucid marginal degeneration.
Okay, anything else? There's only 1 question mark, but give me at least 4 things. You've done 2.
Could be dryness due to lactose and irregular Myers downs.
Okay, 1 more.
Corneal scar.
Very good. Okay, so we'll continue.
So the differential diagnosis for irregular astigmatism does include corneal scar. It does also include corneal ectasias, including keratoconus, pellucid marginal degeneration, which was mentioned, post-LASIK ectasias, and keratoglobus. We also want to consider forms of corneal degeneration like Salzmann nodules, EBMD, pterygiums, corneal edema, and also not to forget ocular surface disease. So with the information we have at hand, what would our next steps be?
Okay, let's ask a PGY4. Oh, are there any of them there?
I think I see,
Four?
The Correll's here.
Oh, Carol, okay.
I guess I want to understand, would you do get a tomography, like to understand if there's any thinning of the cornea?
Anything else? What have you not done yet? That's a pretty big part of a clinic visit.
Things like a, I guess,
History.
sorry?
History. Ask
So-
questions.
Yeah, I guess we get more of a history as to why this happened. Sorry, I missed the first minute of the presentation.
Oh, that's somewhat important. So call a friend.
I think
Oh.
physical history.
Oh, Mina, okay, you said take a history. So what on history would you ask?
I mean, I asked, is there any previous injuries? Was there any procedure done? Because I'm thinking more corneal scars and then any surface disease. Also, any medication history if she's using any sort of drops, any previous infections. I would focus on that first.
Okay.
Aerobic.
Yeah,
Family history?
Apnea.
good. I'm hearing the right answers. Just keep shouting them out. You can have 20 residents in a room interviewing one patient.
Floppy eyelids.
Good. Okay, so you're still missing like a big chunk of what you would do in a clinic exam. I think I just gave you the answer.
Yeah.
Okay.
Slit lamp exam.
All right.
Okay, so we'll start with the K values. In the right eye, the values are 42.7 and 40.91. In the left, 42.8 and 41.4. And like Dr. Chan mentioned, most importantly on the slit lamp exam, there is evidence of bilateral lag ophthalmos with the cornea staining in SPK and a pattern of interpalpebral staining on the right and inferior corneal staining on the left. Moving on to the pentagram, which was mentioned by one of the residents, this is the pentagram of the right eye. And on the top left, we see some inferior steepening that may perhaps look like keratoconus, although it's really not shifted temporarily. And the numbers at the apex are reading 44.7, which are not too high. The Kmax on this reading was 44.9, which is pretty within the normal range. Now let's look down at the pachymetry just below, and I'm expecting to see some thinning, especially at the apex of the steepening, which really isn't there. The thinnest local point is 596 microns. So both the numbers and the locations in the right eye are not fitting in with the pattern of keratoconus. And we move on to the anterior, the front and the back elevation photos, and they're well within the normal range. We are expecting to see more steepening in the posterior elevation photos, but this is definitely within the normal. So overall, this photo is not too convincing. If we move on to the left eye, it's about the same clinical picture. The Kmax is a little bit higher, 46.3, which could be the upper limit of normal. Maybe can pass as a keratoconus suspect. However, the thinnest local point is 610 on the pachymetry, definitely not thin. And again, the anterior and posterior elevation maps are normal. So yes, when we are evaluating a patient for corneal ectasia, corneal steepening is very important, and that can be evident on the corneal topography. However, we still need to check for anterior and posterior elevation, especially with the posterior elevation being a more sensitive marker for early keratoconus changes. We also want to look for thinning on the pachymetry, and these last two things can only be obtained on tomography.
And just one last point, you want to be able to match the thinning to the steepest point. For keratoconus in particular.
Now, on the tomography, we do have an extra tool called the Bellin-Ambrosio Enhanced Ectasia Display. This is based on the tomographic elevation data from the rotating Scheimpflug camera. It provides a more comprehensive keratoconus screening index. So to briefly explain the Bellin-Ambrosio display, what it does is it takes the anterior and posterior elevation data, which are usually matched to a best fit sphere. Now, in the presence of keratoconus or any ectasia, the cone will noticeably cause a steepening of the best fit sphere. This minimizes the difference in elevation between the cone's apex and the best fit sphere. What the enhanced display does is it takes this one step further and provides an enhanced reference surface. It does that by calculating 3.5 millimeters from the cornea's thinnest point and taking it off of the algorithm. This produces an enhanced best fit. Now, the difference between the standard and the enhanced best fit indicates a change in elevation, which is a useful tool in identifying ectatic protrusions on the corneal surface. So in the example we have in front of us, the before photos of the right eye on the top shows numbers that are reading +8 in the front and +17 in the back. And after the enhanced best fit sphere, they are now reading +20 in the front and +60 in the back. The difference map below is colored in red, indicating a significant difference between the before and after readings. A yellow map, for example, would be a suspect, and a green map is one that is not statistically significant. So now let's apply this knowledge to our patients. We'll start with the inferior two maps, indicating the difference between the two maps above. And they're very clearly all green. This tells us that there is no statistical difference between the two maps above. The final D value is 0.84, and also in white, indicating normal. This number reflects a deviation from the normality indices from the front and back elevation maps, and from the pachymetry progression, as well as from the progression of increase in thickness, the numbers just behind. All in all, the Bell and Ambrosio display tells us that the software itself has no suspicion for the presence of keratoconus. Same thing goes for the left eye. The final D is 0.04, and the maps are in green. So what is really going on with our patient? I think it's safe to say at this point that there is no presence of ectatic disease. Our patient is simply a myope who has experienced ocular surface disease and epithelial changes, giving a keratoconus-like picture. However, we've established that there is no thinning and that there is no elevation abnormality. And if you look at the pattern and the distribution of the SPKs, this mainly involves the interpalpebral area and the lower cornea, which makes inadequate blinking and exposure keratopathy the more likely clinical picture. So when we talk about the goals of management, if we're discussing keratoconus, the first goal is to treat any underlying conditions. So we advise the patient to stop rubbing the eye, to treat any symptomatic itchiness if that's the driving force, including using olapatadine, treat any atopy and ocular inflammation. So for example, use anti-inflammatories, which our patient is on, and treat dry eye disease. The second goal is to halt any progression of corneal steepening, and then we offer corneal collagen cross-linking. And lastly, we do want to improve her visual acuity with spectacles, soft contact lenses, rigid gas permeable contact lenses. And obviously, if the patient cannot tolerate contact lenses, we can offer corneal ring segments, DALC, or PKP.
Okay, so for this patient specifically, with the lag ophthalmos, maybe I'll ask Prem, what's your step-up therapy for a patient with lag ophthalmos and symptomatic changes on slit lamp exam?
So I'd start off with artificial tears lubricant, follow them back up. Depending on how much a lag ophthalmos is, if they're already like this, start seeing what they're using. If they are using some sort of lubrication regimen, then I might consider a temporary tarsorrhaphy, as we've done for a few patients.
Specifically, what do you write on your prescription for your lubricant regimen?
So I would do artificial tears every hour while awake for someone like this, knowing that they probably won't do it every hour. And I would also do ointment in addition to that every 4 hours and at night. If it's an older person, I might do ointment a little bit more often and tears a little bit less, just because I know they won't be able to instill the drops as frequently and to keep the eye lubricated throughout the day. But again, for a younger person, tears more often because they're probably using their eyes more, don't want blurry vision, and they might be working. So every hour to 2 hours for drops, and ointment at least every 4 hours.
Okay, and then she's like 30 something. She's got a busy life. She can't spend her whole day with drops. What's your next options for her?
Yeah, so you could, they're different therapies. There's restasis, there's Excedra. I think so far, at least at St. Mike's, we'd often start with restasis. So I might consider restasis 2 times a day. That depends on their insurance coverage though. If they don't have insurance coverage, then it might be a little bit more difficult even with the card. But that would be my next option. If they have,
This is like an exposure, mechanical, anatomical issue, right? So she's been on restasis for a few years already, and she still has these changes. So in terms of, other options, you mentioned tarsorrhaphy, but she doesn't obviously, as a young person, want to be sort of disfigured there.
so can we try maybe at night a tape tarsorrhaphy? You can try punctal plugs, although it depends if they have like blepharitis as well or blepharoconjunctivitis, because that can increase the amount of inflammatory markers, maybe not make things better. And if we had an oculoplastic surgeon or person who might be able to put a gold weight in, we could try a gold weight as well.
Yeah, so I think in her case, it's more because she's had congenital ptosis surgery, right? So it would be hard to operate on an eye that's already had some sort of, the gold weight wouldn't really help in her case. She has closure. It's just that there's not full closure. So I'm trying to get you to say possibly a scleral contact lens actually in some of these patients actually does help as a therapeutic means for their ocular surface disease. But I'll just let Sheikha conclude.
So going through all of the management for keratoconus, I think what we've all agree on is that our patient actually needs optimization of her ocular surface. And Prem has gone through a lot of these. We do start with lubricants. Those include preservative-free artificial tears, gels, ointments, anti-inflammatory drops, which she's on cyclosporin. We do want to encourage nutritional support. So omega-3 fatty acids, autologous serum drops, platelet-rich plasma, amniotic fluid extract are all options within our reach. Lid margin hygiene is actually very crucial. Basic hygiene includes hot compresses, but we also can step it up with LipiFlow, IPL, lid scrubs, and topical antibiotics if needed. Finally, there are adjunctive therapies that we can use to either enhance the environment that she's in with humidifiers. We improve her mask fit and her mask seal. We can also try to eliminate any surface toxicities or inciting factors, including drops that contain BAK preservatives, NSAIDs, glaucoma drops, and soft contact lenses. We want to modify any systemic therapies that she's on. And like Prem mentioned, you can do punctal occlusions or scleral contact lenses.
Yeah, okay, thank you. So that concludes our first case. Maybe while we're switching over screens to Waleed's 2 cases, you can make him host.
Clara, you make a really good point here. I think you've got to just try to figure out what is the underlying problem. And it's not so much, I'm not convinced, at least I haven't seen that she hasn't been producing tears. The underlying physiological problem is her anatomy, it's exposure. And I think I certainly agree with using non-preserved tears and ointments at night to try to improve the SPK inferiorly. She presents a real challenge because of the previous surgery on her lids. You can't do a lid lengthening procedure. And I know very well that people don't like tarsorrhaphies. They're extremely effective, but they don't like it. Yeah. And I agree. I think probably the best option here would be to try a scleral. It would also be worthwhile asking if any of her family members ever see her sleeping with her eyes open at night, because that's another possible area or time when she could get increased exposure. And things like taping her lids shut. It's hard to, in terms of patient compliance, but maybe some ointment at night.
Yeah. Okay, so next we have Walida presenting an interesting case.
Can we mute switch places?
Yeah, now we're good.
Okay. Okay, so my name is Walid Al Sarhani. I'm one of the PGY2s in the program. I'm here to present a couple of cases. I'll start with the first case. This is about a 36-year-old man presenting with redness of the left eye for 10 days. He does not have any previous eye problems, and on past medical history, he was found out to have HIV, which was treated with undetectable viral load. So the story started with the disseminated skin rash, vesicles, and pustules involving the face, trunk, back, arms, and legs. And then 2 days later, the patient started developing fever, chills, joint pains, back pain, and night sweats as well. Prior to that, the patient admitted that he had engaged in 2 sexual encounters with 2 different male partners. On day 7, he started developing a red eye, and then 10 days later, ophthalmology was consulted. When we were consulted, examination of the red eye was pretty normal. Examination of the left eye showed a visual acuity of 20/50 and a pressure of 12 millimeters mercury. On the slit lamp examination, the patient had irregular.
Let's call on someone.
Okay. Can one of the residents describe what they see in this picture?
To pick on someone since we can't see.
Let me see.
Maybe we'll go PGY2 for this one.
Want to pick Dr. Chan or?
Go ahead.
Okay. Safwan, can you describe what you see in the picture?
All right. Okay, I'm PGY2 again, no problem. So this is a slit lamp photo. Then you can see most strikingly in the center of the cornea, there is this like area of like epithelial and subepithelial haze, and there's like an area of epithelial irregularity and subepithelial haze and an infiltrate. Adjacent as well, adjacent to this, it looks like the cornea. There is yeah, there's this like satellite white dots. Yeah, so I would say like again, this is like epithelial and subepithelial irregularity with subepithelial haze and radiating.
Yeah. The white dots are KPs. Yeah, so basically, as you mentioned, the picture shows an irregular epithelial ridge with underlying disciform round corneal edema, and below it there are like several large KPs. The anterior chamber reaction was low grade; it was half cells, and fundus examination was normal. So, what is the differential diagnosis of a patient with keratitis and skin vesicles?
PGY5.
PGY5. Do you have any PGY5s?
No.
No.
Okay, I can see. Do you want a PGY4?
Yeah.
There's, I can see Taylor. Taylor, do you?
Syphilis, maybe, monkeypox. I guess HSV as well. Although it, you know, VZV, but probably syphilis.
Molluscum.
Yeah, it's
Maybe
not,
ectopia as well.
it's not for sure.
Yeah, you basically got all of them. So it's as you said, HSV, varicella zoster, molluscum, and monkeypox. So the next step, would be, what would you do in this case? A PGY3.
Okay, so I guess here we have the vesicles or the skin rash, and then we have the the corneal lesion, I guess I would make sure I do a full dilated eye exam, just make sure there's no vitreous or retinal involvement. These lesions don't look, to me, I'm not sure if I can scrape them and send them or anything like that. So that might not be where I can get a sample, but I could take a scraping of the cornea potentially and send that for microbiology.
Mhm. Any specific tests in microbiology?
So I guess like going back to that differential, so we want to make sure we get a viral swab for HSV, VZV. And then we would do like a culture sensitivity on all the regular plates. And I don't recall if we asked about contact lens, but if that's part of the differential as well, then making sure we get acanthamoeba.
Okay. So we sent for conjunctival swabs and they came back negative for HSV, varicella zoster, and cytomegalovirus. And interestingly, the conjunctival swab as well as skin lesion swabs and blood PCR, they all came back positive for monkeypox. So the patient was started on an oral antiviral medication that was used in the treatment of smallpox. It is recently approved by the European Medicines Agency in the treatment of monkeypox, and it's called tecovirimat for 2 weeks. And then 2 days later, we started the patient on prednisolone acetate due to the presence of stromal inflammation, as we do in herpetic stromal keratitis. And then 2 weeks later, the patient's symptoms went away and he was left with a small anterior stromal scar, as you see in the picture. So what is monkeypox? Monkeypox is a poxparity virus that is similar to smallpox. The first case was reported back in Congo in West Africa. And in 2022, monkeypox virus was declared a global health emergency by the WHO after spreading to more than 72 countries. So the ocular involvement of monkeypox has been reported to be somewhere between 4 and 5%, and severe ocular features are more common in unvaccinated people against smallpox, which may indicate a cross-activity of smallpox vaccine against monkeypox virus. The most common eye manifestation of monkeypox is conjunctivitis. However, there are case reports of eyelid vesicles and conjunctival vesicles occurring with monkeypox. So this is a case of a patient with monkeypox who was found to have eyelid vesicles in both of his eyes, and this is another patient with eyelid vesicles, and this is a patient with monkeypox who had conjunctivitis and a conjunctival vesicle, as you see in the picture. And this is a case series that was recently published in 2023 in the Ocular Surface Journal, showing 3 different patients. The first patient with eyelid vesicles, the second patient was an HIV positive patient who had PUK and conjunctival PCR came back positive for monkeypox. And the third patient is also another HIV positive patient who had conjunctivitis with a positive conjunctival PCR for monkeypox.
Viral count on this patient.
Yeah.
HIV load on this patient.
Yeah. So they did not report in the case series the viral load of HIV, but the latter 2 patients were HIV positive. So the presentation of this case resembles herpetic keratitis and something called ocular vaccinia, which occurs secondary to accidental inoculation of the smallpox vaccine into the eye, and it occurs rarely in about 10 to 20 cases per 1 million smallpox vaccinations. So the ocular features of ocular vaccine are exactly the same as herpetic, conjunctivitis, epithelial keratitis, stromal keratitis, interstitial keratitis, endotheliitis, and anterior uveitis. Viroptic has been used classically in the treatment of ocular vaccinia. It's an anti-herpes virus that inhibits viral DNA synthesis, and it's used 9 times a day. And obviously, due to the fact that it's not present it's not available in Canada, we did not use it in this case. And obviously, it has a potential corneal toxicity. That's why we avoided it in this patient. The antiviral that was used is called tecovirimat. It's used in the treatment of smallpox, and it's recommended for the treatment of severe disease of monkeypox. And as I said earlier on, it was recently approved by the European Medicines Agency for the treatment of monkeypox. So in conclusion, it's really important for ophthalmologists to consider monkeypox when they see a patient with keratitis or conjunctivitis in the presence of eyelid vesicles or disseminated skin rash. And it should be part of the differential diagnosis of herpetic, varicella zoster, and also adenoviral conjunctivitis.
Yeah, I'm curious if, Alan, have you seen any cases or, you know, Amandi's running in the Emerge clinic at Kensington, any other, I mean, I think at St. Mike's, it's a unique patient population, so they had quite a bit of patients who presented with various presentations of monkeypox.
I've not seen it, Clara, not as of yet, at least.
Well, I haven't seen it either. And I did have a question for Walid, actually. You know, in July, it was declared a global emergency by the WHO. Have cases gone down? We haven't been hearing much about it in this calendar year. Have cases gone down? Was it vaccination? Do we know?
Yeah, I'm not sure about like the vaccination, but I know that the smallpox vaccination is stopped in 1972, and because of the eradication of smallpox. But I'm not aware of the exact numbers in Canada or even in the world about monkeypox.
Yeah, I think they actually started vaccinating people and high-risk healthcare workers. So I assume that would have brought down the rates, because a lot of the problem was that people were not, they weren't using precautions, contact precautions, when examining the patient, and then that's how it's transmitted is like through contact with the lesions. So, it's just from an eye perspective, any kind of EKC suspect that comes in, once again, use contact precautions, any sort of vesicular rash presentation in the patient on history or obvious on the face, you should also use contact precautions. In terms of rates in Canada, I think it has plateaued through to 2023 of February. This is just sort of the graph of the counts. The Canadian, what is it? It's through the Canadian Health Canada website where they keep track of the cases. So in total, confirmed cases as of February 3rd was 1460. So that's sort of plateaued now. It actually hasn't gone down. It's just sort of plateaued, interestingly. Any other questions or comments?
How often would this manifest in the eye, like monkeypox? I know we all know that it does, and we saw a good example of that. How frequently would this occur?
The rate of
I think some of them, in terms of serious ocular findings, I don't think we have an exact rate from how frequently
the ocular manifestations. Yeah, so the ocular manifestations are have been reported differently across different studies.
Yeah.
The rate was higher in the West African variant, and it's definitely lower in the European variant. The recent reports, they estimate the ocular involvement to be around 4 to 5%.
Oh, that's good.
Yeah.
So it's much lower than herpetic.
Yeah.
Because herpetic, I think, is 20. Is it? I forget the exact rates. Alan, do you remember? For HSV, how frequently it affects the eye if someone has oral lesions for it to. I feel like this is a question for the residents.
We all ask about oral involvement when we think about herpes simplex. I don't know about you, but I have not found a great correlation between oral involvement. We know it's a cousin, but I haven't found a great correlation between oral involvement and ocular involvement with HSV. Nahal, you?
I echo your comments. I think one of the things in history, though, that if sometimes you're not sure what's going on, you have herpes on your background, on your differential, you may want to ask for a history of cold sores. I think that's the main reason I asked for it. Because if someone says in their young person, they said, I've never had cold sores in my life, you may want to actually do an HSV titer just to see, and you could potentially rule out HSV in someone who they thought might have HSV. If it comes back negative, then okay, this is not HSV. If it comes back positive, it doesn't help you because many people do have HSV and it may or may not be HSV in the eye. if that makes sense.
Yeah, one of the things I found very useful is, the unilaterality of HSV. And also asking about a prior history of red eye on the same side. And that I find to be a more helpful historical question that we can ask patient to try to make the diagnosis.
Yeah, I mean, definitely in the differential for HSV appearing ocular presentations, I think jumping to syphilis on an exam might be a little bit presumptuous. So, I've set up these cases in the presentations as if it's an oral college exam type of STEM case, ask the question. So when the residents are approaching cases like this and just preparing, when you're commenting on your differential, just start with common things being common, jumping to syphilis. You can have syphilis on your differential, but it just makes the examiner worry that you're going to miss the basic, more common diseases first.
Dr. Shah, I have a question here, if
Mhm.
possible. So I'm just wondering, for this patient, did their vision improve after treatment? And do you usually always treat monkeypox associated keratitis, or can you just like wait it out and with supportive treatment? I mean, like antiviral treatment.
Yeah, most of the time it is just supportive treatment. The reason that this guy got this special tecovirimat that was actually shipped to Toronto with like armed guards from a facility where they store the drug because it's in short supply out in, I think, Winnipeg somewhere. The reason was that if it's life or like organ threatening, so vision being organ threatening, the patient was actually able to access the special drug. But if he wasn't at a center that specialized with HIV and had a lot of monkeypox patients, I don't think he would have actually been able to access the drug. And so in the States, people have been using still Veroptic. I think Veroptic is still accessible in the US. Do you remember any other options for treating that we talked about for him? It's just that.
Yeah, so because of the presence of stromal inflammation, we decided to treat the patient. And obviously, this is not based on clinical trials because no clinical trials have been conducted in such a case. We decided to treat the patient as we treat herpes virus to start prednisolone acetate like 48 hours later. Yep.
That's a good point. So there are studies in rabbit studies where they looked at different ways to treat monkeypox in the rabbit studies, and the rabbit corneas where they just used steroid alone did horrible. They basically perforated, and just like HSV, if you just treat it with steroids when there's active virus, it will do really poorly. So just using the study principles from these lab studies, we extrapolated to figure that, okay, let's start the antiviral component of treatment for this patient, and then we can delay the steroid onset of treatment, even though most of his symptoms were inflammatory with the KPs and the stromal edema. And then the epithelial irregularity we thought was just secondary to kind of that microcystic edema, and the epithelium was getting a bit roughened. So when we approached this case, we really had no experience. It was just drawing on our, understanding of basic lab studies on rabbits, and then using principles of treating herpetic disease. Okay, so thanks. I'm gonna move on.
Okay, so we'll move on to the last case of the day. This is a 79-year-old lady presenting with a 3-day history of blurred vision in the left eye, no previous eye trauma, and she had pseudoexfoliation glaucoma in the left eye on alpha-GAN treatment, and her past medical history is positive for chronic lymphocytic leukemia, which was under remission, treated, and she had also hypertension, dyslipidemia, and osteoarthritis. The most recent CT scan, which was done 1 week prior to her presentation, showed no evidence of chronic lymphocytic leukemia with no lymphadenopathy or splenomegaly. Her medication list included acalabrutinib, simvastatin, ramipril, trazodone, amlodipine, and duloxetine. And examination of the right eye was pretty normal. Examination of the left eye showed a visual acuity of hand motion, a high pressure of 29 millimeters mercury, and she had a mild corneal edema with 1.5 millimeter hyphema, pseudoexfoliation material at the pupillary margin, and no neovascularization of the iris was found. The differential diagnosis of spontaneous hyphema. So the differential diagnosis of spontaneous hyphema include iris and angle neovascularization, iris tumors, which may also cause neovascularization, juvenile xanthogranuloma, which may cause Teuton cells on microscopy, and Fuchs heterochromic iridocyclitis, which may cause bleeding, especially with anterior chamber paracentesis, something known as Amsler's sign. Uveitis glaucoma hyphema syndrome is another possible cause, and medications such as antiplatelets and anticoagulants may cause spontaneous hyphema. So the workup, platelet count, WBC count, coagulation profile, all came back normal for this patient. And does anyone want to say what would be the management in this case?
So we spared you the differential diagnosis, thinking that this case would run late, so we didn't get a chance to pick on anyone. But this was actually a Royal College STEM question for me in my year. So hyphema was the case, and there was, at least 6 minutes discussion on differential, how to manage and everything. So why don't we find someone to answer?
Yeah. Let's see.
Okay, PGY 3, you're on call.
I think it's still just me here, so.
Okay.
I can do it. I
Okay.
can do it. So you want, like, head of the bed. So first I guess we want to assess the hyphema. And here, in the previous photo, I didn't see like a huge amount, but there is a bit of a layer there. So also wanted to check the pressure, and I don't recall now, but I think it was normal. So in her case, we essentially want her to be on bed rest or semi-bed rest, like to not exert and to not lift heavy weights head of the bed up, or essentially we don't want her to be lying flat on her back when she sleeps, or bending over, or moving the eye too much. So then into the medical treatment of the hyphema, we can go with steroids and potentially start prednisolone, maybe like 4 times a day, depends on how significant the hyphema is. And in addition to that, like cycloplegia with either atropine twice a day, or we could do cyclogel sometimes like 4 times a day, because we really want to make sure the iris isn't moving at all. And where else? So if pressure is not an issue, we could maybe hold off on that for now.
The pressure was 29.
Okay, so the pressure is an issue. So in that case, we could start her on something like Cosopt. I think one other thing I was thinking about during the differential, like not necessarily in her case, but in just spontaneous hyphema, is sickle cell. So if sickle cell is part of the differential, we might want to avoid carbonic anhydrase inhibitors. But so essentially we want to treat the pressure as well. Yeah.
Okay.
So anytime prior to, on your exams, if you're asked, how would you manage? If you have not said the words, I would do a complete history and physical and dilated fundus exam, just spew it out, like do that as your first comment before you actually go into the details of the case, because that's always like 1 point. So just, easy points to score.
Okay, so we managed the patient with, as you said, bed rest, head elevation, prednisolone acetate was started. We added Azarga. She was already she has been already on alpha-GAN for her pseudoexfoliation glaucoma. And after 2 weeks, the hyphema resolved. We did gonioscopic examination and dilated fundus examination. Everything was normal to look for a source of the hyphema. However, her IUP remained at 26 despite on maximum medical therapy. She was referred to a glaucoma specialist who did her a pressure flow microshunt procedure, and her pressure is normal on off medical glaucoma therapy. It's
Taylor, is Taylor there?
Yeah, I'm here.
Okay, what is this pressure flow microshunt? And why would they have used this?
Well, how early was she referred? Like, was it directly after the hyphema resolved?
Yeah.
Okay. I mean, a present flow microshunt's made of like a SIBS material, which is a very inert material compared to other devices that are put in the eye. I don't know specifically why they would use it in this case. It is a blood forming procedure, so it's similar to a trap in that sense, but it is similar like to a trap dissection, but you use the present flow to create the lumen instead of creating a flap and a punch. So I don't know why specifically they chose a present flow. Like a tube probably would have worked as well. In an eye that's prone to, I guess, did we figure out why that she had the hyphema? Did I miss that?
That's coming up.
Okay.
This is actually just purely of interest because I was surprised I didn't know why they would have picked it either. And so I figure with your interest in glaucoma, you might have seen some other cases where this was selected as the tube of choice.
Yeah. I mean, a lot of glaucoma specialists are turning to pressure flow instead of doing a trap. And so, I mean, I don't know specifically why it was chosen in this case, especially in this spontaneous hyphema case that we don't know the reason for the hyphema yet.
So it's a non-valved tube basically, but it's smaller, it's like a smaller lumen is what I'm getting.
Yeah, it's similar to like a Zen, but it's just a larger lumen than a Zen, and it's a different material, and it's a little bit more rigid. But I don't know why specifically in this case they decided to choose a pressure flow.
Is it maybe because her eye pressures were like not 50? They were like only, 29-ish, 30.
Well, maybe. I mean, if you were choosing a tube, like a different type of tube, like an Ahmed or a Bearvelt, like you would choose those in cases where there's like, if you had like neovascular glaucoma, the eye is like maybe ischemic, like those type of situations. Whereas a pressure flow, if you don't have that ischemic drive or the, then maybe this would, they thought this instead of like a trap. That's sort of the choice. You wouldn't do a trap in like an ischemic eye, you would probably do a tube. So that's probably the decision there.
Well, thank you. You can go do your glaucoma fellowship and come back and tell us more.
Okay, after managing the patient, we needed to figure out why the patient had hyphema. So the possible causes of hyphema and leukemia. So the first possibility could be neovascularization of the anterior segment, which can result from marked leukocytosis and hyperviscosity of the posterior segment and the release of VEGF. And there has been reports in the literature of leukemia causing progression of diabetic retinopathy or causing a diabetic retinopathy similar like picture with neovascularization of the iris and the posterior segment. However, in this case, her WBC count and fundus examination were both normal. The other possibility could be thrombocytopenia, but her platelet count again came back normal. So we decided to review the medication list again, and surprisingly, one of the medications, acalabrutinib, is associated with bleeding, and it's a Bruton tyrosine kinase inhibitor that causes apoptosis and death of B cells, and has been recently approved by the FDA for the treatment of chronic lymphocytic leukemia and some types of lymphoma. It may cause bleeding. With BTK inhibitors, bleeding events are usually minor, and they have been estimated to be 40%, with only major bleeding events occurring in 4%. And major bleeding events occur because of the major bleeding events include upper GI bleeding, intracranial bleeding, or epistaxis. The BTK inhibitor side effects reported in the literature are mainly associated with another BTK inhibitor called ibrutinib, which is used in some types of leukemia. And there was a case series of 4 patients developing anterior uveitis, another case of cystoid macular edema, and subconjunctival hemorrhage as well. So in conclusion, medications are an important cause of spontaneous hyphema. Acalabrutinib can cause spontaneous hyphema because of its effect on platelet function and not platelet number.
Great, thank you. That's nicely presented. Yeah, so I'll just open the floor to comments and discussion from the other participating specialists on the call. We see hyphema from trauma, from drug related. I think we have these newer, like not just heparin or not just what's the other warfarin. Like in the past, it was just easy. You stop the warfarin, you can reverse, you can give iron and reverse the effects. But now there's patients who are on these long acting, like really, we don't understand the mechanism, but you just by stopping the drug does not stop its effect on the blood and the poor ability to clot. So I'm just wondering if other people have seen issues with other drugs causing problems with bleeds, I think vitreous hemorrhage or hyphema spontaneously even. Amandeep, have you seen any on call? Like, I guess these are kind of.
Oh, these are pretty rare cases. I'm wondering, I guess this patient presented initially at the time of the hyphema. We don't have any prior history, but I do wonder if the pseudoexfoliation played a role, and if there was some pre-existing pseudoexfoliative glaucoma, whether undiagnosed. Because
No, she had known glaucoma. So the glaucoma issue was just exacerbated by, I think, the bleed.
Okay.
Yeah.
Sarah, that was a really interesting case. Thank you. I just a comment about the glaucoma. It's interesting to see how these blood forming MIGs have really become a standard in glaucoma surgery, and we're seeing much less TRABs being done now. So when I look at the Kensington data, I mean, it's something like 20% of the surgeries are TRABs, and things are moving towards these blood forming MIGs. Why the PreserFlow over something like a Zen? That's a really good question. It would be interesting to hear from the glaucoma specialist.
Yeah. Okay, great. Well, thanks for tuning in. There's no other comments. That wraps up our Grand Rounds cases today. And thanks to the residents that we could call on. Lone PGY3.
Thank you, Waleed and Sheikha. That was great presentations. Thanks, Clara. Appreciate
Okay,
it.
we'll take a break and then we'll come do I'll come do the teaching session at about 8:45. I just have some post-ops. I'll see you later.
Thank you.
All right, guys, thank you very much. Great job once again, Sheikha and Waleed. And thank you, Clara. So enjoy the rest of your weekend, everyone.
Thank you. Have a good one.
Thanks. Great presentations. Thank you.
Thank you, Dr. Chu. Bye.
Bye.
Great presentations.
Thank you.
Bye.
Bye.